All right. Hi, everyone. We're going to go ahead and get started while our presenter is on her way here. She'll be here in just a couple minutes. So I'm going to go ahead and get started with some announcements. My name is Nicole Johnson. I'm the program coordinator for Buckeye Wellness out of the Office of the Chief Wellness Officer. And it's great to see all of you here. A couple of upcoming events that we have in November for the next Lunch and Learn. It'll be on the 18th. It's moved up a week for Thanksgiving. It'll be in the same room, the BRT room 115, or the live webcast if you aren't able to make it in person. Next Friday, there is an all-staff wellness event with President Johnson over at the RPAC, and then also a live webcast. But if you want to attend that, there will be President Johnson will be making some remarks. Bern Melnick, the University Chief Wellness Officer, will also be speaking a little bit. We'll have some stretching and movement sessions. So a really fun, good event to kind of kick your morning off. It starts at 8 a.m. over at the RPAC, like I said. Just a little save the date, mark your calendars. The Dodgeball Classic is back on December 15th over at the RPAC. Registration will be out and coming very shortly, so you can start thinking about getting some teams together, and we hope to see you guys all there. And I will be sending out slides and all this, so you guys will have it all afterwards, so you don't have to remember everything I'm saying right now. And then, as always, our continuous programming is our group fitness classes. We have them throughout the week. We have some different yoga and some different Zumba classes. We have some early in the morning, some around lunchtime, and then some are in the evening if going after work works best for you. And during the presentation, as always, the usual, you can save your questions for the end. With the remaining time, we'll go through questions then. If you're online, you can type it in the chat box. I'll be monitoring that and then reading them back to our speaker. And I'm going to go ahead and introduce her here. So our speaker today is Dr. Bridget Oppong. She completed her general surgery residency at the University of Rochester School of Medicine and completed a breast surgical oncology fellowship at the Memorial Sloan Kettering Cancer Center in New York. She has been a practicing attending surgeon for 9 years and began her career with a faculty appointment at the MedStar Georgetown University Hospital until 2017. She served as medical director of the Capital Breast Care Center in 2012 to 2017, where she supervised a culturally sensitive navigation-based screening and outreach program. She transitioned to co-medical director of the Reston Hospital Center breast program, overseeing the future growth and development of the breast surgical oncology service line for 2 years. Currently, she is an associate professor of surgery and attending physician in the Department of Surgery, Division of Surgical Oncology at the Ohio State University Wexner Medical Center since August of 2019. Her area of expertise is in the management of breast disease with specialization in the surgical treatment of breast cancer within the James Comprehensive Cancer Center. Her academic interests lie in navigating disparities in breast cancer management and outcomes. This is augmented by her new role as the Cancer Center's Deputy Director for the Center of Cancer Health Equity, where she focuses on outreach and engagement within the Black community and increasing awareness of clinical trials and enrollment. And she just walked in, so that is perfect timing. So please join me in welcoming Dr. Bridget Oppong. Let me get your slides pulled up here.
Thank you so much.
All right, sure. And then this is the mic, and then if you want to walk around, you want to carry this one, that one, whichever you prefer.
All right, well, good afternoon, everyone. Sorry I'm late. I had actually, let me just blame the James. They were late, so it wasn't me. It was the OR. And thank you all for coming. This is towards the end of Breast Cancer Awareness Month, so it's a very fitting topic. My hope is to review just general breast cancer information and then really kind of take it to what we can do to sort of advocate for ourselves and to improve our health. And of course, as healthcare workers and researchers and educators, we're probably the worst offenders. but not taking care of our health. So this is definitely going to be relevant to us. Okay. All right. So again, I'm going to talk about epidemiology of breast cancer. We're going to focus on some risk factors, some things that strategies to reduce that risk. And then we're going to talk about screening. So just to get an idea of the lay of the land, and I think those of us who do cancer research see this slide a lot. The most commonly diagnosed in American women, I think I lost this mic, is breast, and that's 31%. And for men, it's prostate. So what this means that in a woman's lifetime, 1 in 8 will develop breast cancer. And what this means is that also every 3 minutes, we'll find a diagnosis across the country. Annually, we'll see nowadays approaching 300,000 new cases of invasive breast cancer. We also have intraductal cancers, and I'll go into a little bit what that distinction is for those of you who don't know. And then we see about a little over 40,000 women will die every year. And this is just a reminder that male breast cancer does exist. I know a lot of men say, well, we don't have breasts, but you do. You have breast parenchyma, and 1% of the cancers that we see every year will be in men. This equals almost, again, approaching 3,000 cases per year. But you can see that the incidence for men compared to the 1 in 8 or 1 in 10 for women is much higher. There's 1 in 1,000. Okay, so the interesting thing about breast cancer incidence is that it varies a lot based on geography. So in red, these are the areas that are sort of hotspots, if you will. And of course, Ohio being the Midwest, we're sort of in the middle. But for our local statistics, we see in the state roughly almost approaching 30,000 new cases annually. So the incidence is roughly equivalent between Black and white women. And to the right, you'll see, this is national data from SEER, sort of the differences in incidence based on race and ethnicity. Breast cancer is also the second leading cause of cancer death after lung cancer. And I mentioned before the annual numbers, the over 40,000 deaths we see a year. Now, when it comes to mortality, we still also see differences, and this is a really large, or the largest difference when it comes to different races and ethnicities. We see that breast cancer mortality is 41% higher in Black women compared to white women. And you can see the numbers below, looking at our local area, the state of Ohio. And what this means is that the 5-year survival is 78% for Black women compared to 92% for white women. So you can see this is a really wide gap, unacceptably high. And to the right, you'll see the different mortality rates, again, in different races and ethnicities. So this is hopefully not to torture anybody with back in the day biology, but I think it always makes sense to sort of have an understanding of how breast cancers develop. Here's an anatomic sketch of the breast. You can see here the different levels that consist of the breast parenchyma. What we really focus on, because that's where the disease is predominant, is in the breast lobules and the ducts. So if you think of the breast as a milk producing factory, the lobules are the glandular cells that produce the milk, and the ducts carry the milk to the exterior. So those are the two cell types where we see breast cancer. So we tend to get ductal cancers and then lobular cancers less commonly. It's also important also to see the lymphatics, because breast cancers are solid tumors, so they spread via the lymphatics compared to other tumors which spread via the bloodstream. So that's an important distinction. And clinically, so you'll see that when we examine someone in our breast clinics, we make sure we examine the breast, but also the lymphatic basins, particularly the axilla or the armpit. All right, so here is again a depiction of the breast and how it's really interconnected to the axillary lymph nodes. Again, theoretically, we think that breast cancers are all. Oh, I didn't do that. Did I press something? Okay. All right, good to go. Sorry about that. Hopefully nobody lost their hearing. Again, if you look to the first sort of slide or the first depiction, that's what a normal duct looks like. These again are the tubes that carry milk to the exterior. And the lining of this structure is really where most breast issues or including cancers develop, right? So when we see that the cells that line the ducts can proliferate, they can increase in number, they become atypical, abnormal, and these are all sort of histologic differentiations. And then they can turn into ductal carcinoma in situ, where it's confined. Again, you can configure, or you can imagine that ring contains the cancerous cells. Then the last step being the invasive ductal carcinoma, where that lining is breached and the cells have the potential to travel. Okay, so again, just a refresher, we have invasive ductal, we have invasive lobulars. Within these, we also have breast cancer subtypes. So the one thing that patients always say is that they think of somebody that they know that had cancer, and they automatically assume that their experience with their treatment is going to mimic that individual. And the first thing I tell them is that there's different types of breast cancers. Okay, so how we come up with the subtypes are based on receptors. And for breast, we look at 3 different receptors: estrogen, progesterone receptors, and then HER2. So based on the positivity or negativity of these 3 receptors is how we generate the subtypes. And the most common subtype is the ER/PR positive and HER2 negative. And you can see here the breakdown based on the receptors. Okay. So risk factors. So we talked about sort of how or at least scientifically, how we theorize that these cancers develop. Now, what are the risk factors? So most cases are actually sporadic. So again, this is something that we really try to educate patients on, because everybody wants to blame something, right? Or somehow there's a self-blame, or they want to blame some kind of habit that they had or some kind of behavior. And the reality is that with the information that we have, we don't know. And most breast cancers are sporadic. There's no familial predisposition. There is a 10% subset that do have a hereditary syndrome or genetic mutation that we currently can classify. And there's also an additional 20% who have a familial predisposition, but yet we haven't been able to characterize that particular gene or mutation. All right, so general risk factors: as all people age, cancers develop. I showed you one of the earlier slides that men get prostate cancers most commonly, women get breast cancers. All right, so female, older age, certainly having a genetic mutation in the BRCA1 or 2 genes increases the lifetime risk. The risk factors that I have in red are sort of the newer risk factors that we educate patients on, and that's density. And I'll go into what breast density means, alcohol consumption, and then also lastly, obesity. So more on the hereditary breast cancers. These are, again, BRCA1 and 2 most commonly. That was the first gene, or the first 2 genes that were discovered that were associated with breast and ovarian cancer risk. And you can see that the lifetime risk is up to 85%. So it's really important that if you see a patient who has a history of a lot of breast and or ovarian cancer, that we screen them, make sure they get genetic counseling and testing to see if they have one of these genes. Now, over time, more and more genes have been discovered. So currently the panel is approaching up to 40 genes. So imagine we started in the 90s with just BRCA1 and 2. Now we have a much more extensive panel, and every couple of years, new genes come up. So I tell patients, if you've been tested, found not to have a gene despite your family history, every 3 to 5 years, you should get retested. All right. So as promised, breast density. This is something that I think is a newer concept. So I always like to review it, because not many even providers or researchers are aware of how significant density is. So the main tissue types in the breast are fatty tissue. And then we have stromal tissues, which contains collagen. So when we say density, that's the ratio between this fatty tissue versus the glandular elements or the collagen, right? So, and as women get older, the breasts become more fatty, so they become more fat replaced. And that's when we see what we call technically ptosis, or the drooping of the breast, because we lose that collagen. So the density matters because, one, it really impacts the ability to detect abnormalities on the mammogram. So you can see here sort of the BIRADS, the levels, and these are the categorizations, and there's some others, but this is the most common one to categorize breast density. Level 1 is a really fatty breast that doesn't have very little glandular elements, with level 4 being extremely dense. So you can see that level 4 has a lot of that whiteness, that thick tissue. So you can imagine if there's a tumor in that level 4 extremely dense breast, it's going to be a lot harder to characterize. So that's why density matters. All right. Also, we found that density is actually also associated with an increased breast cancer risk, right? So initially, we just thought density was something that complicated the imaging quality, right? That sort of caused issues with the ability to detect tumors. But now we also know that having dense tissues in itself is a risk factor. So that's really emerging data. And based on that, there's legislation. This came about initially maybe about 2012. And I know it started in Virginia through a lot of advocacy. Because of the data that I just briefly showed you, there was a push for the density grading to be disclosed to women, right? So for those of you who've had mammograms or seen reports, now typically there's a density grading that you'll find on your report. And also, if you're extremely dense, there's additional recommendations that will be given to you because now we know that you're higher risk. And also that you may need supplemental imaging because the mammograms are more complicated to read. All right, so lifestyle factors, and these are things that everybody wants to know because how can you empower yourself? A lot of what I tell you just sort of seems sort of predestined, right? Like you can't control your genes, but there's also a combination of just nature, but also sort of your lifestyle, right? So the first thing is alcohol consumption, and there is data that individuals, and these are longstanding, more like older studies, but there's a significant number of studies that we still hold this to be true, that a higher alcohol consumption is associated with increased risk of breast cancer. And that's because, at least theoretically, breast cancers are majority estrogen driven. And we think that if you have a high history of alcohol consumption, the liver decompensates, there's more estrogen produced, which can in turn stimulate the breast to produce these tumors. Right. So we encourage patients to limit alcohol consumption to just one beverage a day. And this can be depressing for some, but unfortunately, here we are. And if you have to have it, I always have this picture of the red wine because at least you get the cardiovascular benefits, right? So you get a twofer. So again, just one, and I mean one, right? So we need to be mindful overall. All right. And the other thing is, again, these are all risk factors that now we're sort of gaining more traction or gaining more attention is obesity and breast cancer. Now, again, we histologically always assume that fat cells are really inert. They don't really do or produce anything, but that's not true. And fat cells are actually hormonally very active. They produce estrogens for sure, but also can impact the insulin pathways as well as some inflammatory markers. So an increase in body fat can increase estrogen production, which can in turn stimulate breast tumor formation, tumorigenesis. So again, we see studies that, and this association is more robust in women who are postmenopausal, that a higher BMI or body fat percentage increases a woman's lifetime risk of developing breast cancer. So with all that being said, what can we do? So until we get that wonderful vaccine to have a prevention for breast cancer, really what we have is screening, right? So we have secondary prevention in the form of screening, and that's really the most important strategy as to what we can do to reduce mortality. Mammography has been shown to reduce breast cancer mortality, and this is particularly in the older group, by about 30%. In the younger ages, there's still some controversy, but overall, most studies do show or trend towards an increase in benefit towards mortality reduction. So just to drive the point home, if you look at these Kaplan-Meier curves, you see the survival rate does differ based on the early detection, right? So the blue line is cancer that's detected based on mammography compared to something that the patient or a physician or any provider can detect on clinical exam. And you see that sustained gap in the mortality differential. All right, so when we talk about screening, most commonly is mammography, which is a picture that you see here. For those of you who haven't had it, it's not that bad. That's one thing I've had it myself. I just had it. And, it's not pleasant, it's not fun, but it's quick and it's not that uncomfortable. And I tell patients, if you feel like it hurts like hell, something ain't right. So make sure that you give feedback to the mammographer or the technician that, hey, this is uncomfortable, because you do need compression in order, especially if the woman has a larger breast, in order to see the entire surface of the breast. But again, it's not meant to be something painful. All right, now the screening guidelines is constantly controversial. The old guidelines recommended screening to start at 40 and to be annual. Then we went to starting at 45, some say 50, and some say every other year instead of every year. So there's a lot of confusion, and these guidelines differ based on the different societies. So the American Cancer Society has different guidelines, NCCN has different guidelines, and then the US Preventive Task Force has a different set of guidelines. So that makes it very confusing. And that makes our job more difficult, right? So, because some women, some populations don't want to do it anyways, right? So if we're going to go hedging and say, well, you don't even know when I should start, and there's all of this controversy, then it's like, well, forget it. I'm not going to do it. So personally, I still advise patients to start at 40. But keeping in mind that if there's a family history, that they need to take that into account. So if there is a significant breast cancer history, screening should start 10 years younger than the age of the youngest affected. So hopefully that makes sense. So here's the different screening guidelines. Again, the US Preventive Task Force, ACOG is the Oncology Society, and then American Cancer Society. So here we usually quote the NCCN guidelines, but ultimately there's always a caveat. So the fine print in all of these recommendations is that you take into account the patients, or the most commonly the women, but of course some men, take into account their personal and definitely their family history, right, to recommend the age that they should initiate screening, and also sometimes the frequency. All right, so things that are controversial is the frequency. Is it once a year? Is it every other year? Of course, when you should start is a big one. It's sort of the big bridge that needs to be addressed. And then what kind of mammogram, right? Should I get the 2D or should I get the 3D? And now we have contrast enhanced mammography. So there's constant advancements in the technology. And then should I get supplemental imaging? So there's a lot of still some grumblings and controversies for all these patients. So when I say new technology, actually 3D is no longer new. I think it became more, easily accessible around 2012. Because I remember I finished fellowship in 2011, and that the next year, at least in the DC area, more women started getting it. And what this does is that you can see it offers a much better detection of tumors. And it does this by subtracting a lot of that density that we talk about. So if you look at the picture I have here, the 2D, this is what I call the old school mammogram. That picture, you can see, looks like abstract art, right? You don't see anything. And then you add the 3D technology or the tomosynthesis, and you can see now there's a discrete density or nodule that's detected. So it's really important. And it's overall, this technology has increased detection by about 35%. So I tell patients it is worth getting, so confirm when you get your mammograms that it is 3D. And now most insurance companies cover it. I think when it was first available, you had to pay a supplement. You had to pay, I think, at least in my area, it was about $75 extra. And, for some women, that was definitely cost prohibitive. But, I encourage those who could afford it to definitely do it. But now it's standard in most places. Like for us, all our screenings are 3D at this moment. So supplemental imaging is something you recommend for women who have high density or have a high risk, right? So if someone tells you that you're high risk, we want to do more for your surveillance or your screening than just the mammograms. And this is a depiction of what's called ABUS, or the automated breast ultrasound. And this is not my favorite technique if I want a woman to get additional imaging or supplemental imaging, because it's very operator dependent. Right. So basically, the ultrasound is scanning the entire breast. And I think it really the technology hasn't been to the point where I find it reliable. So some patients come in with it and it's fine, but that's not what I personally recommend. In place of that, I tend to recommend MRI as supplemental imaging for somebody who has high density or has elevated risk. All right. And there is really data supporting that the MRI should be added, particularly for the high risk population, even the BRCA1 and 2 carriers, that the MRI technology is good enough now that we can tell women you don't need to have, prophylactic surgery or risk reducing surgery. You can continue to have surveillance, but we need the mammograms and the MRIs. So these are women that have imaging every 6 months, and we alternate the different modalities. All right, so how we're doing with the screening. So we have Healthy People 2020, and for those of us who do some of this research, the target was about a little over 80%. And you can, 2020 is done, come and gone, and we didn't make the target. And the reason that we didn't make it is that there were certain populations that were really underutilizing screening, so that they weren't getting screened. So this is where the racial disparities really sort of bore out, because we saw that there was still evidence that certain populations, and not all, you can't generalize, but certain subgroups within Black and also Hispanic populations were not getting screened to the level that they're supposed to, right? So on a deeper analysis, there are reviews and meta-analyses that show that, particularly, again, African Americans are the main groups that have a disparity in mammography utilization, but that there's difference. So I really like this paper because it was very granular in saying, because we always say, well, the Black or African American population, but you want to be as focused as possible and as targeted. For those of us that do community outreach, we need to know the who and the what, so that we can have a more robust message. And the subset analysis show that the younger group and also the older groups, the greater than 65, are the most at risk for falling behind on their screening compliance. And then also within the Hispanic population, it was, the 40 to 65 age group. Okay, so there's definitely work to do in this space. And some of the barriers that have been discovered, of course, poverty, right? Because this links to all the other social determinants of health actually will lead to people not obtaining healthcare, and especially screening, right? Because screening, it's something like you're asymptomatic. So you can imagine if you have limited resources or any healthcare barriers, that's sort of always going to be last on the list, right? Because especially breast cancers, you don't feel anything, unless it's really locally advanced. But most women have zero symptoms when it comes to breast tumors. So it's something that if you have any other sort of social economic impediments, it's not going to be a priority. And so insurance status is really important. And we do have a lot of programs, such as the breast and cervical, the BSEP program, that we can help women who don't have insurance or who are underinsured to obtain screening. And this is constantly, you'll see it in the media, it's always in the talks, like Medicaid expansion. Part of that is to provide additional funds to support screening for breast cancer. And also in Obamacare, they had a provision for to make sure that screening services were covered by the different payers. So in addition, and it's not just the insurance. So these are what I call hard barriers, but there's additional barriers that are really unique to individual patient populations. There's lack of knowledge about breast cancer and screening, because people don't understand, why do I have to get it? Like I said, breast, you don't feel anything, right? And if you're asymptomatic, you don't have any problems, how do you encourage someone to do something about a problem that's not really bothering them? So that's ultimately the barrier. There's also cultural beliefs. I've had patients tell me I'm not getting it because I know somebody who had a mammogram and then, something happened to them. They died, or then they had the cancer. And they're not linking that the mammogram detected the cancer, it didn't cause the cancer. So those are some of the sort of myths that you have to address based on the different patient populations, and also bad experience. So if you go to a place and they put the squeeze on you and you say, this was so painful. I had one lady say it was more painful than childbirth. So I was like, I don't know what kind of kids you had. But she said that this mammogram was the worst. And again, that's abnormal. It should not be that uncomfortable. But, those are things that will deter someone who already has a little bit of hesitancy to go ahead and obtain screening. All right, so overall, so now we have the 2030 target. So hopefully we'll make it. we got some years ahead. And basically now we need to address the underutilization in certain subgroups. So again, for 2020, we focused, or at least the earlier, these programs started in about the 80s. And it's always sort of the Black population, which is a really, really heterogeneous group. And which, I mean, everybody's like, well, duh, right? Everybody knows that Black could be, like, my family's from Ghana, so that's West African compared to, African American compared to Caribbean. Those are all very different populations with different barriers that need to be addressed to increase mammography utilization. So I think our next step is to really emphasize how research what these barriers are and to find unique ways to tailor interventions to get different groups to get mammography. All right, so I wanted to leave a lot of room for questions because don't nobody want to hear an hour-long lecture at lunch. So I made sure to save half our time for questions and answers. But in conclusion, to improve breast cancer outcomes, we need to really stress prevention. That's the most that we can do until, and prevent by that. Hopefully we'll have a vaccine. There's plenty of trials that are being done across the country, and hopefully one of them will prove effective. But we need to follow the screening guidelines. And I tell patients, whatever guidelines your particular doctor is picking, just stick to it because mammograms work based on the habit. So you can't do just one. And that's the other thing patients tell me, well, I had it 10 years ago. No, you need to keep doing it, right? Because it's based on the comparisons over the years. And also lifestyle factors. So we do know it's not just familial disposition or genetics. There's also some lifestyle factors that can help reduce risk, including weight management, reducing alcohol. And also, I didn't go into things, but like healthy eating. You want to reduce processed foods, exogenous hormones. And lastly, education, increase awareness and education. I think most people, when you convince a population or a community of the benefit of it, most of them are willing to do it. They just need someone to take the time to explain. All right, so I'd like to thank you all for coming and spending your lunch with us. So I thank and I see my chairing squad from CCHE that's here. I don't know if there are people from surgery here as well, and also American Cancer Society, they provide a lot of the data that I shared with you. And you should have my slides. So if there's any questions, obviously feel free to reach out. No, that was New York fast, right?
Good. So, for everyone in person and online, before we get to questions, there will be an evaluation. If you're here, you should have gotten it right when you checked in. Before you leave, if you could fill it out and then either return it back to the table where you checked in or leave it at a front table, either works. And then if you attended virtually, you'll be getting it sent out in an email afterwards. And you did receive the slides before this, but I'll also resend them out afterwards, just as a reminder that you have them. So we had some questions come in online.
Sure.
Leaning over the table. So the first question that we had come through was, do you find more insurance companies paying for MRIs?
That's a great question. So actually, yes. Some insurance companies will want a risk calculation. So that's something I didn't include, but part of the screening guidelines should really take into account your personal history or your lifetime, your individual lifetime risk. So I personally use Cusick or IBIS score to determine risk. And if your risk is more than 20% over your lifetime, then you're considered high risk, and that's justification for us to get supplemental imaging. So in those patients, then the MRIs are typically covered. And sometimes they'll push back, and but armed with that information, they want to see the risk score. And if we give them that and it's over 20%, it's not an issue.
Thank you. One of our attendees online, Bibiana, said the Christina Applegate Foundation has a fund for MRIs. So,
oh, great.
She put her email in there if anyone wanted to contact her about that.
Yeah.
Another question online was, what is the chance of developing cancer if diagnosed with moderate bilateral atypical duct hyperplasia once you've completed 5 years of raloxifene?
Raloxifene, yes.
Yes.
So that's one of our risk reducing strategies. So having atypia increases your lifetime risk by about fourfold. Right. So this is the group that we follow. I follow them in my clinics, also in our high risk screening clinics. And just as the patient reported, what we do is that we will add things like the MRIs for supplemental imaging. We see the patients every 6 months, and we talk to them about chemo prevention. So we're sort of backing away from surgical risk reduction, because I mean, that's still an option if a patient really pushes for it. But because the imaging quality is so good and we have medical options, that's really not, something that a lot of women choose.
Thank you. I'll do one more online, then I'll get some people here in person. This individual asked, how do you know if you have dense breast tissue and if you should start screenings early?
Sure. So again, you should really try to get an idea of your family history. So just talk to particularly the women and the men, because men can have certain cancers, that will, that are associated with some certain genes that also can increase a woman's risk of breast cancer. So talk to your family, and what you want to do is to get the ages. So find out what cancers people have had and at what age they were diagnosed. Because again, for breast cancer, we want you to start getting screened 5 to 10 years younger than the youngest affected. All right. So, but if everybody was elderly, for example, then you can start screening at the, standard age of 40.
Do we have anyone in person who would like to?
First off, thank you so much for your presentation.
You're welcome.
I really appreciate hearing a little bit more about the impact on minoritized communities, barriers, and needing access. I'm curious if you have looked at sexual and gender minorities in any research that you've done, and barriers to care or additional educational information that our providers should be addressed with as they're supporting this community.
Right. No, and thank you for that question. That's a great question. That's on our list for sort of our focus within CCHE. Is one of our long list of things that we're looking to address in the community. Sometimes it feels like a really monumental task, but definitely the LGBT community has specific screening needs that really haven't paid attention to, right? So if you go to like the CDC website or the American Cancer Society website, there are some screening guidelines. We've actually produced sort of a health education pamphlets and reviews, just sort of a quick review so that people know what they should be doing. And of course, it gets complicated for patients who are, for example, transgender, because depending on what organs remain is how we need to really tailor screening. So you're absolutely right that we need to do the research to find out what the gaps are in that population. But the little research that exists, we do know that they are definitely under utilizing mammography and all screenings for other cancer types. And just in general, that there's sort of a sense of trying to limit engagement with the healthcare system, because of negative experiences, because of not feeling that they'll be accepted. So actually, in our breast center, we're also going to start asking those questions, right? Because we ask about race and ethnicity, but we're not really asking about sexual orientation. So those are things that we're looking to initiate moving forward.
Anyone else in person have a question? Another one come in online. This individual was asking about the increased screening. They were told they have very dense breast and have family history of breast and ovarian cancer and an immediate risk for breast cancer. They've already met with a genetic counselor. Should they follow up with any other physicians other than their PCP and OBGYN?
So I'm glad that they've already met with the high risk screening team. So definitely it's a good idea to get the genetic counseling, because they will guide you based on the family history. They literally will build like a family tree, and based on that, they can advise you which tests that need to be sent for. And based on that, they actually will do a post-test consult with the patient and tell them, like, basically you have this, if you have a mutation, this is what the cancers or the cancer sites that you're at risk for, and then they will initiate part of that to initiate a screening plan. So definitely you're in the right place. They will tell you based on the results of the screening, which additional teams, like do you need screening for pancreatic cancer, for example, or screening for ovarian cancer. If the results of your test show that you need those services, they will send you, they will refer you.
Anybody in person have a question? No.
This one.
Thank you, doctor, for your presentation. I just had a question, like pertaining to, have you heard of like any links pertaining to, I guess, external care, preventative care, things such as like, I guess, bra sizes, like sleeping with bras, things such as that?
Yeah, there's a lot of concern about things like, underwire bras, deodorants. I get that a lot. And I know there's some products out there that sort of say that they remove the metals, which have been shown to be associated with cancer. There's no evidence to support that. But again, a lot of patients already do it. Like a lot of my women who have a high risk of breast cancer or have breast cancer will start using these alternative deodorants or don't use it at all, which I don't advocate. I do not advocate that. But they do have lots of natural options. So I think, and you'll see over the last couple of years, there's so many brands out there. There's so many brands. So if you're concerned about that, there's no scientific evidence that, it should be that way. But if it makes, women comfortable, I always say go ahead. But there's definitely alternatives. And the other things that I get a lot of questions on is like microwaves. I get questions on cell phones because I think Dr. Oz did some show and the woman swore she got breast cancer in the same spot where she puts her phone while she's working out. So there's no evidence for that because my phone's like in my back pocket, so there's no buttock tumor that's grown there. So, there's a question here.
So you said getting that yearly exam, however we do it, whether it's be MRI or 3D, is one of the best ways that it's detected, and rather than going to the doctor and they discovering it. Then this thing about doing the self-exam, I wrote down, I'm going to do better about doing that per month. Okay, just say that I didn't do that. What's the risk that if I have something and it takes me a whole year before I go get my next exam, that I'm going to complicate matters? It's going to be
Right. No, it definitely does. So the self-exams, we actually no longer include that as part of a screening strategy. I think the reality is that most self-exams will pick up more benign things and it creates a lot of anxiety. So overall, the benefit of it sort of, did not outweigh the risk. So we tell women that you don't have to do it. But I personally tell women you want to be familiar with your breast because, the saddest things when you see women, just like you're saying, sometimes women can get interval cancers, and those are cancers between the annual screenings. These are not common, thank goodness, because they are extremely aggressive, right? Because most breast cancers are estrogen or hormone positive, they're very slow growing. But the interval cancers can be the more aggressive subtypes, so that in that year space, they can really change. So those are the ones that tend to be missed, or like let's say the woman has a history of a prior mammogram and there was nothing on it, and now she's got this big mass. So you're not missing anything if you're not comfortable doing a self-exam. But I always tell patients it just makes sense to just always look. Sometimes there's other things too that can change in the breast. There's other, not necessarily invasive cancers, but other conditions that involve the skin of the breast. And sometimes there's some changes to the breast that can indicate other systemic problems, right? So other like autoimmune diseases and stuff like that. So it's always a good idea to look. I'm always amazed at women. Oh, I don't look at that. I don't touch that. I'm like, really? So look in the mirror, and it doesn't have to be monthly if you don't want to do it, but just overall, just be familiar to how the breasts look like and how they feel like.
We can flip back to an online question. This person is asking, is breast cancer in younger women more aggressive than those cancers in women over 50?
That is another good question. So in a way, yes, I'm always going to sort of give you a yes and no. And the yes part is that one of the more aggressive, I don't want to say most aggressive, but the triple negative breast cancers are very aggressive. And this is a subtype that's more common in younger women, particularly African-American women. It's also more common in women who are mutation carriers. But overall, it does seem that the incidence is increasing just over the last decades among young women. So unfortunately, personally, my youngest patient has been 19 with breast cancer. So, it's just, it can happen. So I always caution sort of primary care providers that don't ever blow off a breast complaint because you never know. I see patients all the time, college students who say, well, I've been going to the doctor. They said it's nothing. I'm too young to have breast cancer. And that's not true. It should always be ruled out.
Anybody else? I love this. What's the question?
Can you speak to the varying opinions of the age of first screening and why that is? And if there's been any research done of, screening under 40 and what that looks like?
Yes. So the whole goal of screening is that you want to have the benefit outweighing the risk, right? Because the risk of screening is that we're going to find stuff, especially in young women, the breasts are hormonally active. There's breast cysts. There's something called fibroadenomas. These are not cancerous, but they're going to lead to workup, right? Because if we see something, we're going to have to do additional pictures. We may have to do biopsies. We may even have to do surgery to make sure that this is not a cancer. So those are all the things that are adverse consequences of screening in a young age. And then we balance that with truly what is the incidence of breast cancer in younger women? It's much lower than women who are over 60, right? So the average age in this country is 60. In Black women is slightly, is a few years younger, but overall is a disease of older women. So if you think of it as sort of a lay terms, what's more bang for your buck, right? Because the public health teams, what they want to do is that how much money can we spend on this individual to actually affect the outcome, right? So if we're screening, because we can screen everybody, right? But it won't be worth it because most cancers are in the older population. So the data is going to be strongly shifted to showing a benefit in the women who are specifically over 50. Now, the sort of the controversy that we talk about now is particularly in Black women, where, like I said, they tend to get more aggressive cancers, they tend to get it younger. So why are you not screening that population definitely at the younger age? Because that's what's been done for like prostate cancer, for example, or even colorectal cancer. Sometimes they want certain populations screened at younger ages. So I think that's where we're going with breast. And again, it gets very confusing. I wish the U.S. Preventative Task Force would just give an answer, but they're responding to the data, and the data is clear for women over 50 that there is a mortality reduction, and the studies are, really just not supportive definitively when it comes to women 40, and definitely not women under 40. So the 40 and 50 group is gray, is definitely recommended for 50 and above. Under 40, most studies don't show a benefit. But I suspect if you looked at, let's say, an all Black population, that there would be a benefit to screening at a younger age. We just haven't done those studies, so haven't asked that question.
We have about 4 more minutes. Anyone else have a question? No. All right, and I don't see any more online, so I think we can go ahead and end it there. So thank you so much again for being here. This was very informative, so thank you so much.
Thank you.
Thank you to everyone who attended in person or virtually.
Yeah, thank you so much.
Have a great day, everyone. Thank you.